Assalamu alaikum wa rahmatullah. Good morning, everybody. Thanks all for coming today. I'll be presenting about acute coronary syndrome, obstructive disease, and more. The learning objectives of this talk is to review the latest fourth universal definition of MI, review the latest guidelines for the management of STEMI and non-STEMI patients, and finally shed some lights about the entity of MINOCA, which is MI with no obstructive coronary artery disease. When I was preparing for this talk, I had to review lots of guidelines, literature, came across the graphs and diagrams and all of that. And then I remembered these slides from Hector Michelina. Hector is a professor of cardiology of echocardiography in the Mayo Clinic. And he said that intellectualization leading to development of algorithms because it calms the anxiety generated by the lack of control over the dynamic and somewhat chaotic nature of the biological phenomena. But it may limit the necessary individualization process of the medical patient. Understanding the pathophysiological principle and its interaction with a unique patient is more important than memorizing algorithm. Keep that in mind, not just for this presentation, for all presentations. So what is MI? That comes from the fourth universal definition of MI, which was published in JACC in 2018. The definition of MI really evolved over the past 7 years. The first WHO definition was published in the 1950s, and the most recent one was in 2018. So MI, you need to have two problems, or I have to say two aspects. First, you need to have myocardial injury, and you need to have a myocardial ischemia. So what is myocardial injury? Myocardial injury when you have an elevated troponin. Elevated troponin can be acute or can be chronic. Chronic elevated troponin, like someone with chronic renal failure or structural heart disease, where you have persistently elevated troponin levels. Acute troponin rise when you have a typical rise and fall in troponin. This can be associated with a myocardial ischemia. We're going to talk about what we mean about ischemia, or without it. If there's no evidence of ischemia, then this is acute myocardial injury. You can have this with heart failure, you can have this with myocarditis, and so on. And there are many non-cardiological reasons or cardiovascular causes for acute myocardial injury, like a patient who comes with sepsis, with acute renal failure, critical illness, cardiotoxic medications, and so on. So it's important when we say the patient had an MI, even type 2 MI, because I see there is a lot of misconception and people call myocardial injury type 2 MI. There's a difference between type 2 MI and myocardial injury. We're going to discuss that in the next few slides. But in order to call an MI, you need to have evidence of ischemia by symptoms, ECG changes, new pathological Q waves, abnormal wall motion abnormalities, an echo and thrombus, let's say, or occlusion on coronary angiogram. Type 1 MI, which our usual STEMI and non-STEMI, is when you have a plaque rupture and erosion with an occlusive thrombus or even without an occlusive thrombus, with what we talked about as the definition of MI, so ischemia and injury. Where type 2 MI, you don't have a plaque rupture or erosion. It's a supply-demand mismatch. Maybe you have a very significant CAD, but yet you don't have a plaque rupture, or have a vasospasm, or a coronary microvascular dysfunction, which is also a very important entity in terms of MI and chest pains. And finally, non-atherosclerotic coronary dissection. So the diagnostic criteria is the same, but the pathophysiological process is different. Type 3 MI is if a patient comes in dead because of MI with a presumed diagnosis of a heart disease. Maybe you have some new ECG changes, but you didn't prove it with laboratory markers. Type 4, it's PCI related, and type 5 is cabbage related MI. These are the 5 types of MI by the universal definition. So why it's important to differentiate and to diagnose type 2 MIs? Well, in type 1 MI, we have wealth of data, randomized trial, guidelines, thousands of patients randomized to support our treatment and investigation strategies. But in type 2 MI, unfortunately, we don't. And it's been shown that at least 2/3 of patients with type 2 MI have some sort of CAD, and 1/3 of them, they have obstructive CAD and have LV dysfunction. And on follow-up after discharge, these patients even at a higher rate of adverse events compared to type 1 MIs. I think most likely because the complexity of their other comorbidities and the fact that most of them, they don't get investigated and treated for coronary artery disease. So it's important that we have kind of a work frame on how to approach these patients. So if you have someone with a type 2 MI and a patient is known to have CAD, you can decide just to continue their medication, especially if it was in the context of acute illness, critical illness, sepsis, and so on. And on case-by-case basis, you may consider looking again on an angiogram and considering revascularization. But what's more important is the patient that is not diagnosed with CAD. So we shouldn't say that this is type 2 MI, the patient is not known CAD, okay, treat the underlying cause, treat the other process, and send him home. These patients, we should look for functional or structural assessment of the coronary arteries and treat them accordingly. STEMI. So this comes from the 2022 expert consensus decision document on the treatment of chest pain in the emergency room. A patient comes in with STEMI or STEMI equivalent, you treat them according to the guidelines. Very important to keep in mind the ECG findings of a STEMI equivalent. Look specifically for posterior STEMIs. For patients with left bundle or paced rhythm, always look for Scarboza criteria or a modified Scarboza criteria. I prefer the modified Scarboza, it's easier to remember. Look for D. Winter sign. Remember that 2% of prox LADs present with D. Winter sign, not classic ST elevation finding. And finally, hyperacute T wave. These are all STEMI equivalent and should be treated as STEMI. There are the most two recent guidelines published for the treatment of STEMI, 2013, the American, and 2017, the European guidelines. So we'll just go through briefly about what was new in 2017, because we didn't have any updates since 2017. So in the 2017 guidelines, so anything in green is class 1, 2A is yellow, and 2B is orange. So radial axis, class 1, DES is class 1, complete revascularization is class 2A, but remember that was in 2017, and the complete trial was published in 2019, which we're going to talk about in a few slides. Routine use of aspiration, of thromboaspiration, is class 3, yet we use it, and I think every interventionist in the room still use aspiration catheters if they have a huge thrombus burden. The class 3 is the routine use of thromboaspiration. And then about the anticoagulation, bivalirudin and enoxaparin is class 2A. The goal in treatment in STEMI patient is the total ischemia time. And there are two aspects to that. There's a patient delay and there's a system delay. And I think we can work on both. Patient delay, I think it's extremely important, and it's a responsibility of us as physicians to educate patients. We should educate them in any opportunity. In mosques, diwaniyat, social media, we should educate them that when they have ischemic symptoms, they should seek medical advice. I think all of us suffered from late presenters and cardiogenic shock patients because the patient comes in 48 hours later. So this is something we can work on. Now the system delay, alhamdulillah, recently we have more growing number of centers that are providing primary PCI in Kuwait, and I think the next few years we will not give lytics anymore. But the idea that you make a diagnosis of STEMI within less than 10 minutes of first medical contact. And if you are in a primary PCI center, you should achieve reperfusion, like wiring the vessel and restoring the flow within less than 60 minutes. Now, if someone presents within the first 3 hours and you cannot do PCI, then lytics is okay, it's a class 1A. Again, up to 12 hours, if you cannot do PCI, then lytics is okay. After 12 hours, you shouldn't be giving lytics. Primary PCI if they are symptomatic or hemodynamically unstable. And if it's symptomatic, it's class 2A, and more than 48 hours, routine PCI is class 3. This is what we do routinely in our practice. A patient comes in, get loaded with an aspirin and a second antiplatelet. You can argue you want to give ticagrelor or Plavix. Anyway, you have to give a second antiplatelets. Anticoagulation, heparin is preferred. You go radial access, first generation DES, start high-dose statins and a beta blocker and an ACE within the first 24 hours. And on discharge, if their AF is low, you start an MRA and other heart failure therapy. This is the complete trial, which I think is going to be reflected in the new guidelines regarding the complete revascularization in patients with STEMI. So if you come in with a STEMI, you should get all vessels revascularized within 6 weeks, 45 days, according to the complete trial. And it's shown to be superior to culprit lesion only PCI in reducing cardiovascular death, MI, and risk of cardiovascular death, MI, and ischemia-driven revascularization. Now, there's more recent trial, which was published in ACC just a few weeks ago. It's called the BioVasc trial. The BioVasc trial looked at complete revascularization, immediate versus staged. So in complete, you have to do it within 45 days. In BioVasc, you do it immediately. And it's shown to be non-inferior to staged complete revascularization with less contrast and reduction in myocardial infarction and unplanned ischemia-driven revascularization. Non-STEMI, again, we're going to go per the guidelines, the most recent guidelines published in ESC in 2020. In terms of choice for anticoagulation for PCI and fractionated heparin class A, now and then the patient goes for PCI. If they are very high risk, you can give dual antiplatelet for only 1 month, high risk 3 months, and low risk you can give it for a year, and sometimes you can consider extended DAPT up to 36 months in selected patient based on the ischemia risk and based on the bleeding risk. Who should get urgent or early or immediate invasive strategy in non-STEMI? So if you are at a very high risk, that means you are hemodynamically unstable, cardiogenic shock, recurrent refractory chest pain. If you are in heart failure, if you have significant ST depression, these patients should be getting immediate invasive strategy. That means less than 2 hours. Early invasive for less than 24 hours is for patients with dynamic ECG changes and resuscitated cardiac arrest who is now stable without ST elevation. This patient can wait for 24 hours. And low risk, they can go for selective coronary angiogram. Minoca, and this is kind of for the new kid in the block, and you're going to hear about it more in the next few years. This comes from the this document, AHA document published in Circ in 2019. Minoca is MI with no obstructive coronary artery. And I think we are seeing this more now, especially with the increasing number of coronary angiogram that we are doing and the high sensitivity troponin. We are picking more MIs, we are doing more angiogram. I think we are picking more cases of Minoca. It accounts for 5 to 6% of all MI cases. Usually, they are younger patients, more likely to be women, and less likely to be dyslipidemic. Diagnosis should be made according to the 4th universal definition of MI. So you need to have myocardial injury and you need to have myocardial ischemia. And you need to do an angiogram with no more than 50% coronary lesion. So when a patient comes in with an MI, because now you made the diagnosis of an MI, you have elevated troponin, you have ischemic symptoms, and you did an angiogram, and then you see there's no obstructive coronary artery disease. You cannot just say this is Minoca. So you have to look carefully. You need to make sure you rule out alternative diagnoses like sepsis, PE, cardiac contusion, aortic dissection, and other non-cardiac cause. If you don't have an alternative diagnosis, then look again, review your angiogram. Maybe you are missing an obstruction in a minor branch, in a small diagonal, in a very distal PDA. So review your angiogram again, make sure you are not missing any small vessel occlusion. If you don't have any small vessel occlusion, then you have to look, maybe also look for like small dissections. Like be careful for, look carefully for SCAD. And if you cannot find anything, then you have to investigate further. How do you investigate further? Looking for other diagnoses like myocarditis. Myocarditis is not Minoca because according to the 4th universal definition of MI, myocarditis is not an MI. So you do an CMR, if there's myocarditis, this is not MINOCA. If you reviewed your angiogram and the patient had SCAD, you can argue that this is not MINOCA, although different authors have different opinions specifically about SCAD, whether or not this is considered MINOCA. Some of them say yes, some of them say no, and we'll discuss that in a second. Takotsubo cardiomyopathy is not MINOCA. It's the entity by itself. So once you ruled out all of this and you didn't reach a diagnosis, then it's most likely MINOCA. At this stage, now, what the guidelines and what's the recommendation and what's the practice? What they recommended is to do intracoronary imaging if you have 50% lesion, see if there's a plaque rupture, plaque erosion, a calcified nodule, and so on. You can do coronary provocative testing for coronary spasm. You can do FFR and IFR. So you can do all like physiological testing and intracoronary imaging. But let's be realistic. This is expensive tests. So I think the best approach for these patients, also cost effective, is you make sure you rule out other cardiomyopathies like myocarditis, Takotsubo, dissections, and so on. And then if you don't reach a diagnosis, then you say it's most likely MINOCA, because by the end of the day, the treatment is going to be the same. If you have a lesion, you have to put them on antiplatelets, you have to do like good risk factors modification, and so on. But what's been shown, and this is like what's advocate for more testing, but again, it's not cost effective, I think, is if you do coronary imaging, coronary testing, and CMR and thrombophilia assessment in all patients with MINOCA, you're going to reach a diagnosis in most of these cases. What we like to think about, when we like to think about MINOCA, we like to think about it like you have a myocardial injury, then you have a Takotsubo as a separate entity, you have myocarditis as a separate entity, and you have AMI as a separate entity, and in AMI you have MINOCA. But in real life, it's very difficult to differentiate between all of this. It's they interact with each other. Symptoms are similar. Sometimes you have concomitant disease. So in real life, to make these diagnoses, it's not easy. Two slides about SCAD. You guys all know like SCAD is a spontaneous coronary artery dissection. Sometimes you have a spontaneous intramural hematoma, and sometimes there's a communication between the true lumen and there's a leak. And there are 3 types of SCAD. Type A SCAD, when you have some radiolucencies in the vessel. Type 2A SCAD, when you have diffuse narrowing of the vessel, and then, okay. So type A, you have just some radiolucence in the vessels. Type 1, sorry. Type 2 is when you have diffuse narrowing, and then you regain the normal vessel diameter. Type 2B, you have diffuse narrowing to the end, and type 3, it mimics atherosclerosis. So if you have a type 2B, when you have diffuse narrowing and distal occlusion, or a type 3 when it mimics atherosclerosis, you can argue that this is an occlusive CAD. So this is not MINOCA, where if you have type 1 or type 2A, when you have a non-obstructive disease, less than 50%, it's MINOCA. So SCAD is one of these entities that people can debate whether or not it's considered MINOCA, or you can even consider it a separate entity. The treatment, there's currently no randomized data to tell us what should we do for SCAD patients, but there's data from the Swede Heart Registry of more than 9,000 patients of MINOCA, followed for more than 4 years, showing that significant reduction in major adverse events, MACE, in patients treated with MINOCA who are treated with statins and ACE inhibitors. Beta blockers shown a positive trend, but dual antiplatelet therapy for the first year was neutral. So again, after all these guidelines and algorithms, remember what we said. By the end of the day, you need to try to understand the patient's process, the patient's problem, individualized patient care. Thank you very much.